All right, this is our presentation on Spina Bifida, done by Sean, Taylor, and Dalton. In this presentation, we'll talk about kind of what Spina Bifida is in general, as well as some treatment options, both physical therapy based and kind of surgically based. But that's kind of where we're going. So yeah, here's that overview, kind of what spina bifida is, how it's diagnosed, the prognosis of it, and then we get more into the treatment and how it pertains to us. It's definitely more important on our side of things of how we treat it. It's good to know what it is, but at the end of the day, we're in the business of trying to treat it. So I think that's kind of the more important aspect of this video. So, what is spina bifida? In short, it is the failure for the neural tube to close while the baby is in utero. Um, Most of these cases actually don't come with any sort of symptoms, and some don't even know they have the disease, which is that spina bifida occulta. Which, if you look at the picture on the right side, it's that first picture where there's that gap in the kind of the picture, but there's nothing protruding out the back. And then you have kind of this intermittent version where there's a protrusion, but the spinal cord itself does not collapse out the back. And then the most severe case, in which case the neural tissue is compromised. And this is where a lot of your symptomatic populations will occur at. I'm not going to try and pronounce it because I will butcher it, but that is the most severe kind. And like I said, it can be present in several different ways with no neural involvement, which they'll go their life without really noticing they have it, all the way down to being a major impacting force on their life. It is estimated that out of every 10,000 live births, 3.4 will have spina bifida. It'll vary between populations. I think one of the stats I read, the Japanese population, they had like 0.3 or 0.9 or somewhere in there prevalence per 1,000 births. So they definitely had the lowest I saw. And if you had a baby already with spina bifida, your chance of having another one with that same disorder rises about 2 to 5%. And they don't really know the exact cause, but they have some indication that it is linked to folic acid, and that is because folic acid has something to do with neural tube health. So a lot of doctors will prescribe pregnant mothers with some sort of folic acid supplementation. And in the book, it talked about how I think the government initiated kind of putting folic acid in breakfast cereals to try and increase the intake of folic acid among everyone in the United States. So it is diagnosed by blood test. By they observe this kind of protein called alpha fetoprotein. It usually peaks between 6 and 14 weeks in the mother, but then if it exists outside of that time frame, it has a pretty high ratio of being positive for spina bifida. But there are like instances of false positives and false negatives, so they will usually use an ultrasound to confirm those findings. And then obviously after birth, if they come out and you kind of see that deformity, usually in the lumbar spine, it kind of lets you know what it is. But they're trying to find it earlier and earlier so that they can, one, try and treat it earlier. I believe Taylor will go on and talk about kind of some prenatal surgeries. And then unfortunately, there's also that population who decides to terminate their pregnancy because of the potential birth defects that would happen. But that has kind of helped decrease the amount of incidences because they're able to catch it earlier and determine whether or not they think it is worth it or not. Overall, the prognosis is pretty good. It used to be that if you received no treatment, you had a pretty low survival rate, and then with treatment, you were at about 50%. But currently, if you get on top of it and you're willing to put in some of the work for this treatment, it has a current success rate of like 90%, which overall is pretty good. But so the prognosis for these patients is really good in the current day and only getting better. So a lot of the symptoms that these patients will have will really depend on the type of spina bifida they have. Like I said earlier, the Spina bifida occulta doesn't really have symptoms, so that one isn't really going to impact us that much here. But in those more mild or moderate to severe cases, you're going to have a varying array of symptoms. I listed a bunch of them here. I think the book even lists more, but these are the ones that were kind of more prominent. Kind of those motor and sensory functions can be impaired both unilaterally or bilaterally. You can have loss of bowel and bladder control. There's been some tone abnormalities with hip dislocations or contractures. And one of the most common things is the development of hydrocephalus. I know we talked about it a little bit later too, but one of the stats in the book stated that most children will have this Chiari-2 malformation, which leads to 90% of those individuals having this hydrocephalus. And so I'll go on to talk about that here in the next slide a little bit. So this Chiari-2 malformation is essentially just kind of a hindbrain herniation, or where the medulla, fourth ventricle, cerebellum, they all kind of displaced through the foramen magnum. I put an MRI over to the side here to kind of show that it's starting to kind of descend that neural tube there, which I'm hoping you guys can see is not normal. And that just kind of can cause all sorts of complications, such as a hydrocephalus, which kind of blocks the drainage of that cerebral spinal fluid, which will start to cause that swelling of the cerebral spinal fluid into the brain, which can cause a ton of symptoms. Most commonly, the headaches and nausea can be life-threatening. And so trying to get that condition under control is going to be a top priority. It used to be thought that this kind of Chiari-2 malformation was caused by the deformity at the lumbar sacral area where the original neural tube defect was, and that it was acting like an anchor to kind of pull everything down. But they've kind of shown more recently, I believe, in like since '89, that it is actually its own instance of kind of like a pressure difference in there. And then it starts to just kind of suck that part down, and it leads to the hydrocephalus, as opposed to the cord actually pulling itself down because of like the protruded area at the back. But they're still not 100% sure on that. It is just the most accepted theory at this point.
Alrighty, so I'm going to talk about surgical options. There are a couple different ones here, but the first one we'll talk about is fetal surgery. And this is kind of the newer surgery. This one has just kind of became more prominent within the last like 20 years. But typically it happens between weeks 20 and 25 gestation. And it does have about a 94% survival rate, and that's only getting better and better as more research comes out and as it's done more and more frequently, especially now that they kind of have a better idea of what like fetuses are better candidates for this surgery compared to which ones are not. This has not replaced typical surgical routes just because a lot of hospitals are not capable of doing this surgery. But again, as more research comes out, as like newer surgeons are graduating, this surgery is becoming a little more prominent. One plus to this surgery is that it does have a decreased need for shunting, which we'll talk about that a little more with the post-birth surgery. It has been shown to have improved lower extremity function, which I think Dalton will kind of explain some of that to you guys as we move to physical therapy routes and whatnot. And it does have a reduced risk of hindbrain herniation, which that kind of ties in with the decreased need for shunting. The risk factors, though, which, with all surgery, there are risk factors. And although this one does seem to be becoming more prevalent and the better option of surgeries, there still are obviously risk factors. And that would be there is a high risk of premature birth. The baby will still probably need back surgery post birth. It does have an increased rate of infant mortality rate and low birth rates, and it also has an increased infant morbidity. And then for the mother, there's preterm labor, so that obviously goes with the premature birth, a placental abruption, which can definitely make it harder and have like more complications for future pregnancies. So this is kind of just a picture of how that fetoscopic repair looks. They just kind of make an incision right there, and then they go in kind of all, seeing everything via like a monitor, and they can just from there it's pretty much the same surgery as you would do if the baby had been already birthed. It's just they're putting that neuro tissue back in the spinal canal, and then from there they suture it back up just as if they would if the baby was out of the mother's stomach. So surgical options continued. This would be the pre-op assessment. So this isn't the actual surgery. This would just be if the baby had been birthed, they would have to obviously assess it before they actually just started cutting away and whatnot. So the first thing and the most obvious thing that they would have to look at is the location and extent of the back lesion. So um, the larger the lesion and the more neural tissue that is out, obviously the more severe case that we're dealing with. And the larger the lesion also would mean that they would maybe need a skin graft of some sort, just to cover it up after they suture it and whatnot, which would kind of just pose some extra hurdles to go over, like where are they going to get that skin in order to make the skin graft. The next thing that they need to look into is congenital kyphoscoliosis. This is very common with babies that have had spina bifida, and this just poses increased complications with wound healing because if you think about it, with kyphosis, when you're leaning forward like that, that's going to put a ton of pressure on that back skin. So you would need to just kind of take that into account in order to how they would suture it up and whatnot. And then this, if they do happen to have this kyphoscoliosis, this will need to be addressed very early on, more than likely through surgery. The next one is just scoliosis with a fused rib at the level of the lesion. And this is also very common for children that have spina bifida. And if they have a fused rib at the lesion, at the level of the lesion, it's very common to have rapid scoliosis progression. And as most of us already know, with severe scoliosis, it can obviously affect cardiopulmonary function just because you're not going to be able to get that lung volume to expand the way we need it to. You know, we just took a cardiopulmonary test, so most all of us are very aware of how all of that works, or at least I hope that is the case. The next one would be assess cardiopulmonary function. That kind of goes with what I just said. But on top of that, the baby is going to go through a surgery, and this is a baby that is, you know, typically these surgeries are, they try to do it within 72 hours. That's kind of like the thing they're really pushing hard right now is if the baby's born with spina bifida, that they put that neural tissue back in the canal within 72 hours. So anybody that's going to go under surgery is going to need their cardiopulmonary function assessed just to see kind of what it's going to be like if they're put under. Urology, babies that are dealing with spina bifida typically have a neurogenic bladder, and this says may need to be addressed, but if they have neurogenic bladder, it definitely will need to be addressed because this just makes them very prone to infections, especially like UTI type infections and kidney infections. So the main way they kind of go about this is intermittent catheterization. And this is just they have a catheter. I didn't actually see specifically how long of frequency and like how frequently they have it. I just know like I think they have it for a few days and then they don't for a few days. And this is just kind of a good way to make sure that everything in there, all the pipes and everything like that are clean. The orthopedic assessment, this is kind of the least of their worries typically. A lot of hospitals are still kind of pushing for this just because it gives people an idea of what the baby was like before going into surgery. So although it's not a necessity, it definitely can provide valuable information moving forward just because if they didn't have great range of motion or great tone before and then they don't after, or if they do before and then they do after, it just makes it a little bit easier to compare pre and post surgery. So on to the actual surgery. Like I said earlier, the surgery is really pushed to be performed within 72 hours. And this is just to prevent infection on that neural tissue, which can definitely have some like severe complications because that spinal cord is vulnerable to just infections, and that would just make the whole thing quite a bit more complicated moving forward. So the ultimate goal of this is just to place that neural tissue back in the vertebral canal. I mean, seems simple, but that is what the point of the surgery is. And then you want to cover the defect with skin and fascia, ideally with the baby's skin and fascia, and that should all just be done pretty smoothly. And you want it to be flat, watertight closure of the sac. And then the next thing would be to manage the hydrocephalus if present. 10% of babies have no complications and will never need to worry about another surgery. Don't really need to worry about physical therapy. Don't need to worry about really even checkups for the most part. Like those babies can go live a completely normal life afterwards. But the other 90% do develop hydrocephalus. And what hydrocephalus is it's just a increased pressure on the cranium, which is caused by the cerebral spinal fluid. And the reason for this is because when they're spina bifida, where they have that opening, that lesion, that cerebral spinal fluid is actually draining through that. So then once you close that lesion, there's now obviously more pressure, and the baby had went all through its time in pregnancy with that cerebral spinal fluid draining. And now that you've closed it, the body's not really used to having nowhere to send that fluid. So, like I said, 90% of them develop this. 25% of these babies need a shunt immediately. And a lot of times they'll actually put a shunt in as they're doing the initial lesion surgery, where they're putting the neural tissue back in the vertebral column. The other 55% will also need a shunt within the next few days. And then the remaining percentage, which I don't know, what is that? 20% will need a shunt within the next 6 months. So the most common symptom or like sign that they are having hydrocephalus is the sun setting, which I have a couple pictures of this, but it's just where you kind of have that deviation of eyes going downward. And then kind of like John was saying, with hydrocephalus, a lot of times you'll have that nausea, you'll have that headaches, and then also if it does start impacting the brainstem, you will definitely have decreased vitals and possibly respiratory arrest, which that is kind of where it becomes life-threatening. So here's just a couple pictures of that, and as you can kind of see, the front of the skull is very enlarged, and because of that, it's kind of pushing everything else downwards. So here's just two shunt options. At this point in time, typically all we see are VP shunts, but for a long time we did see VA shunts, which is ventricular atrial. And what this does is it moves the cerebral spinal fluid from lateral ventricle and like the brain to the right atrium of the heart. And just thinking of that doesn't really make a whole lot of sense, moving cerebral spinal fluid from your brain into the right atrium of your heart. The reason they've stopped doing this is because of the risk of potential infections in the heart. So the VP shunt, the ventriculoperitoneal, drains cerebral spinal fluid from the lateral ventricle down the neck, under the clavicle, and down the anterior chest wall, just below the superficial fascia. This shunt inserts into the peritoneum, and the cerebral spinal fluid is reabsorbed, and then excess can be excreted. Occlusion happens more frequently with this shunt, but all in all, that's not a terrible complication compared to heart infection. And then it's the most common because of this less severe complications. And we have a couple pictures of these too. So as you can see, one of them, draining that fluid from here, and then you're just taking it to the heart. Where this one, you're draining it kind of down into the stomach almost.
So we're gonna move on to physical therapy and how you would treat it for infants with spina bifida. And so before they go into operation, there's some things you can do. You want to probably take a manual muscle test on the infants. I know it might be tough, but this will help assist the medical staff and the surgeons know particularly possibly what nerve roots are affected if just going through all those. And you want to attempt to do it preoperatively, 10 days after surgery, 6 months after surgery, and 1 year after, just to kind of help keep track of the progression and how surgery did affect their level of function. And you also can work on some range of motion exercises, but just keep in mind that there's some natural contractures, such as like hip flexion, knee flexion, ankle dorsiflexion, which are normal. So you don't want to overstretch that too much. Just go against what is normal. And want to also try to keep the same therapist and the same like nursing staff and doctors the whole time. The family and infants in the hospital, just keeping that consistency during this stressful period for those parents, and getting the same line of communication and education about what's going on, what's happening, and why we're doing everything that we are is important to kind of help calm everything down. And if you keep with the same PT the whole time, you can keep better track of how the infant's progressing and if there's any change in function, if they're getting worse. And they're most likely able to detect subtle changes compared to someone else who just comes in and sees them for the first time or for the first week. And after the operation, like Taylor said, many ones earlier, but some things you can do is do some passive range of motion to affect the extremities and lower extremities. But they should be brief and only performed about 2 to 3 times a day. And you want to perform this yourself first and then teach the parents, just show them how to do it, teach them where to hold on to the legs or anything like that. And they can do this even when they're like changing diapers or anything. But you want to progress to having the parents do it themselves later on. And you also want to go back to the manual muscle test that you did before. So this will help determine if there's any muscle imbalances or deformities that you'll need to keep a track of, and let the surgeons or anyone else who's taking care of the infant know. You also want to help teach the parents how to position and handle their infants, because after surgery, they'll probably have, they'll be sore in the back. So laying supine might not be indicated. And so the infant will be limited to laying prone or side lying and just being able to get the infant up. I think I've read in the book that they'll have the infant laying on their stomach and in the parent's lap as they sit in the chair and rock back and forth, getting that motion and just knowing how to handle the infant without causing any further complications. And PT can also do a sensory assessment so that everyone is aware of possibly uncomfortable positions that will hurt the infant after the surgery. And if they do have a sensory deficit, that you are checking the skin in areas so that there isn't any complications or dirtiness, anything like that. And then for the young child, kind of going at the same thing earlier, communication is key between the parents, all the doctors, because during the first few years, they'll be going to a lot of follow-up appointments after their discharge. So they'll be going all around to various checkups, like neurosurgeon, orthopedic surgeon, urologist, whatever they need. And a significant portion of those children will have a central nervous system deficits. And one of them, notably early on, is instability of the infant's head and upper body. And so, what you want to do is, like we talked about earlier, with the position and handling, knowing how to teach the parents the strategies to avoid severe head tilt angles because since their head and upper body isn't very strong at all, or their coordination isn't there yet, even putting them in the car seat, if they don't put like a towel roll behind their neck, the babies could end up moving their head into a position that could be compromise them. And so you want to try to position the infant in ways that tries to initiate their own head movement, sometimes even providing stimulus. So on the right there, a couple of examples we got from the book. I try to find different pictures, but the top one is having, instead of the baby at the height of your chest, you have them over your shoulder so that he or she can attempt to look around the environment and initiate their own head movement to go look wherever they want. And another strategy you can do to initiate that movement is lay them um, when they're supine, or if they can't be supine, but you can hold them with your hands behind their back and head. And so that they get face to face contact, they get stimulus by looking at you. You can play with them, but you have the support of their behind their back and their head if they need to. And that picture on the bottom right kind of shows it like that, except this is an infant who is able to hold their own head up, but it's along the same lines as that. And as the child grows up, the PT should focus more on objective findings, as well as findings that neurosurgeons and orthopedic surgeons will find as time goes on and more deficits become apparent. Um, so something that you want to incorporate early on as important is riding an equilibrium of the head and trunk, kind of like we were saying earlier, that they won't be strong there. And so, like I was saying in the last slide, you can start with them kind of facing you with their hand behind their back, tilted backwards about 20 to 30 degrees, and try to have them initiate their own movements. Um, this will also cause active movements of the trunk and lower extremities as they're moving more with this. And sitting while moving will achieve this, and this will also work on the child's visual field and hand-eye coordination. And as time goes on and they get better and able to do more movements, you can change the angle they're at. You can make them more diagonal. You can make them work on more rotation. It's just all about where the deficits are and where you need to treat. And at one point, it'll be whenever it's appropriate, you want to try to do similar balance exercises, but with the child in standing. Same thing with like the reaching and the hand-eye coordination equilibrium, because this will give valuable proprioceptive input for the lower extremities and spine. And you also want to teach all this to the family members so that whenever you go, they can do this brief standing with the child for exercises multiple times a day, just get those repetitions. And then while you're there, you also have to assess whether progression to standing is typical or not, and to also just provide appropriate exercises in order to minimize negative effects. Then we get to young adults. Research shows that a lot of the population, as they get older, tends to be a greater disinterest in their personal care, and they actually even begin to procrastinate to seek medical care. And if it gets, there's been very severe cases where this actually results in amputation because they sometimes notice something's wrong, but they just don't think it's that serious, or some of them honestly just don't care, I guess. And because a lot of them are also living with their families, and not many of them are out on their own. They haven't gotten married, and they don't live by themselves. And some research has shown that urinary incontinence is a major role and really correlates with how people with spina bifida view themselves and how they think they could live well on their own. And which is also very important because urinary tract infections are the most reported cause of morbidity in the adult population with spina bifida. And one last thing is kind of a lack of job opportunity for some of those that another reason why they might not be living on their own or trying to be more independent. And that's something we can work on with those patients later on to have some compensatory strategies, either for where their physical requirements are or even possibly mental requirements. And orthotics is pretty broad. It covers a lot. I know we're covering this in Kinslow's class right now, but we know that you want to communicate with the family and orthopedic surgeon to find the orthotic that will best fit and be most functional. That's something that you will find out as you do more assessing as you work with them later on. Just knowing what would be the best fit for them. And it's important to, after they are fitted with an orthotic and one was chosen, it's important to teach them more about how to don and doffing the orthotic, make sure it's a proper fit, as well as the amount of time it would probably take for them to be independent with it and how long they should wear it for throughout the day. You also want to teach them proper maintenance of their orthotic and making sure it's not digging into their skin or scratching or anything like that if they have sensory deficits. And as a child, because a child will grow a lot, and the orthotic might change because they'll have changes in their functional movement, or they'll get taller, bigger, so that you need to upgrade and um, get maybe even the same orthotic, but just a different size. And we know like AFOs and KAFOs are commonly used right now, but for those that are having a higher level of paralysis, specifically the thoracic level, when they're younger, they're more at risk for developing frog leg deformity due to the plasticity of their lower extremities. So there's a lot of times where the total contact orthosis is put on them while napping or at night to prevent contractures. And I just want to talk briefly about reciprocating gait orthosis because this is something that's being used a little bit more. And because previously there was only the hip, knee, ankle, foot orthosis was the only option, but I don't think it gave a lot of hip extension feedback and like just kind of trunk balance with them. So what they did is kind of developed this RGO, and actually turns out it gives better ambulation with an assistive device for those who use it. And so that would just at least show you what it looks like. And wheelchair mobility is going to be important as well because a lot of children end up using a wheelchair, and it has a lot of benefits, especially if they become frustrated with their slow gait or they have trouble going on even uneven terrain. So teaching them how to use it can even increase or decrease their dependent behaviors, and if also help them with mobility to even get to or even move around school. But as a PT, you have to be also aware of all those risks that come with the wheelchair and let the parents know the problem or problems that could arise with it, such as breaking down your skin, pressure sores, might have some spinal problems if they're not seated correctly, um, have even hip and knee flexion contractures. So you might have to even schedule times for them to be up and out of the chair and try to walk on their own. You also want to make sure they have the proper seat cushion so that pressure sores don't happen. And another thing you have to be aware of is if their child is moving very well in the wheelchair, sometimes the parents might just nix the gait training program you have for them. So just be prepared for that. So right now, as the child gets older with PE class, you can even work with their physical education teacher so that you can incorporate activities or sports that the child can be involved with the rest of their class. And you can also work with family members to find sports leagues or activities that the child is interested in, and that if they are limited to the wheelchair and can't ambulate very well, then just having them join those leagues, giving them more information about it, because sports can help with muscle strengthening, cardio endurance, hand-eye coordination, as well as even maneuvering their wheelchair. And so there's a lot more research coming out about aquatic therapy, and it's become a more popular approach. And I know kids enjoy being in the pool, so that's something that you should consider. And I think that's those are our resources, and that's all we have.